I just want to thank you for that wonderful introduction, Helmut. And I just want to say hello to my colleague, Shauna Hudson, who we served together on the Dissemination and Implementation Study section at the NIH for several years. And it's really an honor to be here. These are my active grants right now. So I'm just going to begin, with just some very basic concepts. And many of us already understand what this is, but I always think it's worthwhile to start with the basics and then build up from there. So what are social determinants of health? Well, we know that they are the impact of where we live, where we work, where we learn, play, and even prey on our health. There are 5 broad domains: the social context, which we often hear about, and the healthcare context, which we often hear about within our healthcare settings. But there's also the economic context, which is a powerful determinant of health, physical infrastructure, and I'm going to say a little bit more about this, and the educational context. And it's really important to try to understand healthcare disparities and health inequities through the prism of these 5 domains, because they really are the upstream drivers of many of the disparities that we see in this country. And without addressing them, we're not going to make a great dent in the problem. So what is the relationship between racism and social determinants of health? Well, slavery is at the root of health inequity in this country, and it has its origins in the US in economics, but maintaining it required a brutal system of oppression and subjugation that would have been really hard to sustain if Black people were considered equal. And Frederick Douglass said it the best. He said the whole argument in defense of slavery becomes utterly worthless the moment the African is proved to be equally a man with the Anglo-Saxon. And herein lies the origin of white supremacy. It was necessary in order to scale and translate the practices, the brutal practices of racism into the hearts of the everyday American. Black people had to be considered subhuman. They needed to be dehumanized. And so the dehumanization of Black people occurred formally, legally, through what was called at the time the slave codes. And these slave codes served to keep slaves from rebelling, keep them in order, and extract maximal profits from their blood, sweat, and tears. But years, a few hundred years later, the Civil War took place, and slaves were freed, and the post-emancipation structures of racism continued. This time, the slave codes that were initially created to maintain a white superiority were morphed into Black codes, which were really used to maintain white privilege. The white supremacy in this country cemented itself over hundreds and hundreds of years. And simple emancipation was not going to undo the 100 years of conditioning that took place during the time of slavery. And so white privilege was maintained through these Black codes that really served to continue to marginalize the Black population. And a great example of these Black codes are the Jim Crow laws, which legalized segregation, was responsible for the redlining that stripped poverty from Black communities, responsible for maintaining the saturation of racial bias within the justice system, all of which served to concentrate poverty and concentrate social determinants of health. And so what happened back then was that Black people had poor access to healthcare. That's the healthcare context. They had poor housing conditions, poor physical environments, that's the physical infrastructure context and the environmental context, poorly funded school, the educational context, and poor access to capital. The types of employments that were available were very menial jobs, hence the economic context. And what this all did is they coalesced to create a significant chronic socially structured stressors in Black community, which spilled over as toxic stress, giving rise to maladaptive behaviors and an epidemic, a silent epidemic of mental health challenges, which also served to increase the risk of chronic disease, hence creating the divergence between Black health and white health, and the disparities that we see today. So initially, segregation was legal, but today America is still an extremely segregated society, and it's more of a de facto segregation today. If you look at the segregation index, which is also known as the dissimilarity index, which is the percentage of people needed to move to result in the complete integration of a particular city, it actually hasn't appreciably decreased in the US even today. Today, it's about 60% for most cities. In New York City, where I'm sitting, it's 82%. If you think back to apartheid South Africa in the 1990s, segregation index was about 90%. So, Black people still live in very, very different environments to whites in this country. Some of this is preference. A lot of it is marginalization, racial steering, and white flight from urban areas once Black families move in. And so what happens is that we have marginalization, which really facilitates the type of economic and social deprivation that has led to really poor conditions in communities of color. In fact, the worst conditions under which the poorest whites live is on average better than the best conditions under which the poorest Blacks live. Poor whites are more likely to live in areas with a lower poverty index, more affluent areas, even those that are living in public housing. And so this all has its roots in the structural racism that I described in my earlier slide, which really has followed American history over hundreds of years, and the residue of which we're still seeing today. But how do we define racism? So racism is a system, and this is Kamara Jones's definition, that structures opportunity and assigns value. In the old days, just as recently as 50 years ago, it was a conscious assignment of value. Today, it's much more unconscious assignment of value based on the way people look. It consists of structures, policies, and practices and norms that, and this is important, it unfairly disadvantages some communities and individuals, but it also benefits other individuals and communities. And what the tragedy of this, it really undermines the realization of our collective potential. There are geniuses in our inner cities that are untapped, unnurtured, and we're wasting valuable human resources that could make us collectively stronger and greater as a nation. So racial bias, as we know, which has evolved over the conditioning of American society since the inception of slavery, can be divided into the structural racism that I just defined, but also into personal racism, which is what a lot of people falsely assume to be racism. That's just prejudice between individuals and groups. And then there's internalized racism, which to me is the most tragic form of racism, because this occurs when an individual who's a victim of racism internalizes the value that society has put on his life. And so that individual undervalues himself it affects your aspirations, it affects your fundamental cognitive structures and your aspirations and your dreams and your spiritual your spiritual condition, especially when you internalize the beliefs that the society, through its biases, has imposed on the victim. And I want to say a little bit more quickly, very quickly, about racial bias, because I think it's really important to understand just how deeply embedded racial bias is in this country. You know, Phelps did an interesting study. I'm a neurologist, so I study the brain for a living. Phelps did an interesting study, a functional MRI study, that really, to me, kind of elucidated just how deeply embedded racial bias is. So white subjects were put in an MRI scanner, and they were shown white faces and black faces. They were both familiar white faces and familiar black faces, unfamiliar white faces and unfamiliar black faces. And they all underwent the implicit association test, which tests unconscious bias. They all underwent the modern racism scale, which tests conscious bias. They underwent an eye blink startle response, which is an electrophysiological, electrodiagnostic test for startle. And then they were all asked while in the scanner to press a button if the face that it is shown is the same as the previous face or different to the previous face. And then they looked at, in real time, the activation of different areas of the brain. And what they found was intense amygdala, a structure called amygdala, which is deep within the limbic system of our brains, which is really responsible, is a center that's very much involved in emotional conditioning. They found intense activation of this amygdala structure when unfamiliar black faces were shown, not when unfamiliar white faces were shown, not when familiar black faces were shown, and certainly not when familiar white faces were shown. Only when unfamiliar black faces were shown, this area lit up like a light bulb. And this correlated to the implicit association test, that scores of unconscious bias, but not to the modern racism scale, which really measures more explicit bias. What was also interesting is that when they looked at these responses, they found that the responses, when they looked at it across different age groups, a second study that was done by Telsa that looked at these responses across children from the ages of 14 right the way to age 18, they found that these responses only begin to emerge around age 14. Around 12, 13, and 14 was when these responses begin to emerge. This lighting up to unfamiliar black faces, again reflecting the increasing salience of race across development. And I think this sensitivity to race that's reflected in the amygdala, again, I just want to mention again that the amygdala is really responsible for kind of framing and processing unconscious stimuli that have acquired emotional significance, like fear, for example, or threat. And so the sensitivity to race in the amygdala likely reflects the socially constructed associations and stereotypes that we have in American society, such as Black men are threatening, or it might also reflect the social threat of appearing a prejudice. But what is also important, and this is where hope lies, is that these cultural associations do vary across individuals, depending on that individual's formative experience. And what was shown in these studies, that greater interracial contact, during childhood, significantly diminishes the amygdala response to these unfamiliar Black faces. So how do social determinants of health and structural racism intersect with health and healthcare? Again, allow me to utilize Dr. Kamara Jones's cliff analogy, which I really think is probably the best way to explain the interaction of racism, structural racism, and social terms of health, with our healthcare system and our individual health. So if a group of people are moving towards the edge of a cliff, and one person falls over and lands at the bottom of the cliff, what are our options? Well, if you look at box F, we can station ambulances at the bottom of the cliff and whisk the patient over to the emergency room and treat that individual acutely, emergently, and hopefully patch that individual back together. And that's really what we do with tertiary prevention. It's a tertiary prevention. Another thing we can do is we can put a net, a safety net, halfway down the cliff. So as the individual falls, the individual is caught by this safety net and hopefully doesn't fall through the cracks. And this is what we call secondary prevention within healthcare. And the examples of secondary prevention are screenings. When we screen you for high blood pressure, we make the diagnosis and we treat you and control that blood pressure before it becomes a stroke. Or when we screen you for cancer, identify a precancerous lump and remove it before it becomes malignant cancer. These are secondary preventative strategies. Another thing we can do is that we can put a fence at the edge of the cliff to stop that individual from falling down in the first place and hope that the sheer numbers of individuals pressing it against that fence doesn't cause the fence to break. And this is what we call primary prevention. And an example of primary prevention is, vaccination, which is what we're trying to, immunization, vaccination, very relevant today. We get immunized to prevent ourselves from getting the disease in the first place. It's how we've eradicated a number of diseases. It's why COVID vaccination is critically important. Or we can simply take those individuals who are living at the edge of the cliff and move them far away from the edge of the cliff so that they're not even at risk of falling in the first place. And this is what we call primordial prevention. And this is why, zip code is one of the greatest predictors of life expectancy in this country. In fact, one study in New Orleans showed the zip code can explain differences in life expectancy for up to 25 years. And so these are where the social determinants of health come into play. However, if we look at this analogy one-dimensionally, we really miss the importance of structural racism, because the truth of the matter is some people live at the edge of the cliff. They have adverse social determinants of health. They're living at the edge of the cliff, and they're always, always at risk of falling relative to other people who are living in much better condition. And these differences in exposures and opportunities have a direct impact on our health. Some people also have different access to care. Some people don't have ambulances at the bottom of the cliff to pick them up and whisk them off to the hospital. They have no safety nets, no clinics, to have no access to clinics because they're uninsured for that secondary prevention, or for that matter, that primary prevention. And so differences in access to care plays a very significant role. And then there are differences in quality of care. And some people might have 10 ambulances, beautifully equipped ambulances at the bottom of the cliff, and others have one poorly functioning ambulance with very little resources at the bottom of the cliff. So there are also differences in quality of care. And as I've explained earlier, structural racism is really determined a lot of the marginalization in this country that has led to these differences across these different social determinants of health. But we know from various studies that addressing these determinants play a really hopeful role. And this is a study that was done by Jens Ludwig. It's a landmark study, the Move to Opportunity study. I'm sure many of you are aware of. But what they basically did was they randomized about 4,500 women and children. This was done with the Department of Housing and Urban Development, living in public housing in poor areas by census tract definitions to one of three groups. They either received these special vouchers that were only redeemable if they moved to a richer area with low poverty concentration, or they were given unrestricted, regular unrestricted vouchers, or neither was offered. And these women with their children living in the public housing, they were followed for 10 years. At baseline, measures were taken, including height, weight, hemoglobin A1C, etc. They followed them over a 10-year period, and they repeated these measures. And what they found was that for those families, those women and children who moved from a public housing in a poor area to a public housing in a richer, more affluent, low poverty area, in those families, there was a 50% reduction in the likelihood of diabetes, and very close to that reduction in the likelihood of extreme obesity. Again, showing how powerful these neighborhood factors are. What was also interesting, and we all know, what was also interesting is that there was a positive effect on happiness and well-being, and this is published in Science from this same data set. And also, interestingly, increased college attendance in kids who moved before the age of 13. We know that our public schools are funded through local taxes, and simply moving these families from a poor neighborhood to a richer neighborhood within the same with public housing system, more of the kids were likely to attend college when they moved before age 13. However, with regards to the economic context, there was no effect on economic self-sufficiency or employment prospects. So, there's still other domains of structural racism that is still, applicable. But as far as health was concerned, we saw really, really dramatic results from this study. And so the social context, is also very, very important because, as I mentioned earlier, racial bias in this country is ubiquitous. We've seen it in the housing sector, in the employment sector, the justice system, in our schools. It's even in the technology sector, and tragically, it's also in the healthcare sector. And the Institute of Medicine, for all those interested, had a wonderful report that was published in 2002 that really outlined the differential outcomes that we see in medicine that's been driven by unconscious biases within the practice of medicine. Real procedures, biases with regarding referrals, with regarding specific treatments, with regarding surgeries, outlined in that wonderful IOM article. And so it's telling us that there is real bias within the medical system too. At the individual level, the everyday discrimination scale is a wonderful way to really examine the effect of interpersonal racism. And this was a measure, it's 9 items. These questions seem quite straightforward and innocuous, but they really do, when they occur with the frequency of almost every day, or even once a week, when they occur with such frequency, the sheer barrage of these experiences is associated with increased hypertension, increased inflammation in the body, premature death, and a dysregulated stress response. And this is wonderful work that was done by David Williams. Just to contrast, this is the white privilege measure. I just want to preface by saying even the concept of white privilege tends to be quite defensive. But I want to emphasize that white privilege doesn't mean that an individual's life hasn't been hard. An individual hasn't worked his way tirelessly from rags to prosperity. What it means is that your skin color isn't one of those things making it harder. And this is a simple measure that by Peggy McIntosh that can be used to evaluate the white privilege. And then it's important for us to also, within the social context, look at the adverse childhood experiences that we now know play a really significant role in our health, in chronic disease. And it's been, there are 10 items that can be used to measure this, grouped across 3 domains: abuse, neglect, and household dysfunction. If you layer these awful experiences during a very vulnerable period of childhood, if you layer racism on these experiences, the effects, are exacerbated. And I mentioned child racism as it relates to children, because the truth is that 1 in 5 African-American 5th graders experience racism. And there's a lot of data and studies that have looked at racism in children and their experience in the literature. And so when you layer these adverse childhood experiences to the experience of racism, it's not hard to imagine that these must have not only a mental toll, but also a physiological toll on the body. And the CDC, through their either MMR publication, looked at the dose-dependent relationship between these ACEs and chronic disease. And they found that if you have a score of 4, if you have 4 or more of these ACEs, then you're at higher risk for a whole host of chronic diseases ranging from stroke and heart disease to cancer, diabetes, and obesity. And you also have a whole host of maladaptive behaviors related to psychiatric illness. Depression is a big one, anxiety and depression are big ones, to suicidality, substance abuse, et cetera, et cetera. And so our bodies are really designed and really well equipped to handle acute stresses. The body is really well designed to handle acute stresses. We are even really well designed to handle, frequent acute stresses. This is why we have the fight or flight response. However, a toxic stress can occur when these stresses are so repetitive, so voluminous, so chronic, as experienced by individuals who lack sufficient physical or psychological resources to cope with them, to cope with these stresses. It then becomes toxic. It becomes toxic stress. And there's a lot of emerging data about toxic stress and the physiological response to toxic stress. These chronic, socially structured stresses, these adverse childhood responses, the physiological impact of these are really, really real. What we're seeing now is that they cause increased ambulatory blood pressure, higher ambulatory blood pressure in those who have experienced toxic stress. There's lower nocturnal decline. When we sleep, our blood pressure usually dips. There are categories that there are people who are non-dippers, and there are certain conditions that predispose certain individuals to non-dipping of the blood pressure at night when you're asleep. Toxic stress is one of them. We've also seen increased cardiovascular reactivity in response to these stresses, but also delayed return to pre-stress levels, and also similar reactivity just from the recall of these stresses, which is one of the reasons why rumination is associated with hypertension and elevated blood pressure. We've also seen elevated levels of inflammation, this C-reactive protein, adjusting for a lot of other factors that drive inflammation. There's more and more papers emerging about allostatic load and the weathering hypothesis, potentially driving some of these disparities. And then I also want to mention very briefly the structural changes, not just the physiological changes, but the structural changes that also occur in response to the repeated activation of our fight, flight, freeze, stress response, especially when they're occurring during the developmental years of childhood. What we've seen is that these adverse childhood experiences, this toxic stress, can alter brain wiring and brain growth of certain brain regions, particularly the prefrontal cortex, which is really involved in our thinking and our thought processes, and continues to grow in boys up to age 22 and in girls up to age 23. The limbic system, in particular the amygdala, which really is involved in emotional regulation, and the temporal lobe, especially the hippocampus, which is involved in memory, our memory systems. And so these areas, as a result of this repeated activation of our autonomic fight or flight system, these areas become volumetrically smaller. They are atrophic. And as a result of this atrophy, these individuals have even more difficulty with emotional regulation and other cognitive responsibilities of these particular areas. We've also seen this with social deprivation, and it's also accompanied by some neurochemical changes that occur in response to this cascading system. I just want to end by saying that these upstream factors are the real challenge and where we really need to focus our efforts and in terms of dismantling structural racism. But there are things that we can do at the local level through community engagement, through working closely with community health workers, investing in community health workers, investing in our community-based organizations, because these organizations can not only help mitigate some of the health behaviors at the downstream levels, but they can also help address some of the midstream issues with regards to access to medical care, with regards to some of the physiological resources, and with regards to some of the social support services and resources that are needed. So just community engagement, working systematically with our community health workers and our community-based organizations can really help mitigate some of the downstream and midstream effects that are driving our health disparities and the poorer health outcomes we see as a result of them. So I'm going to end just by emphasizing that one of the things that we must not overlook as we embark in creating a more equitable society is really recognizing that there's some very basic things that we need to do better at, and that is basic health communication. It's really important for us to use innovative, culturally engaged techniques to communicate with our communities of color, with our marginalized communities, and we need to do so with the same amount of rigor that we approach other pieces in the puzzle of health disparities. And for me, health communication is one of these crouching tigers, hidden dragons, and low-hanging fruits that can really begin to really help move the needle in the right direction. So it's one of the reasons why I started Hip Hop Public Health, the organization that we specialize in working with the hip hop community and with our artists and producers to develop using a community engaged approach to develop health promotion resources as well as programs that target communities of color. I'm going to end with a 1-minute video that shows one of our very recent videos that really targets the colon cancer disparities and the real need to increase screening for colon cancer in communities of color.
If you're 45 and over, listen up tonight. Colon cancer untreated can take your life. Get it right, get screened, no time to be silent. Take a home test or hit your healthcare provider. Colon cancer in the black and brown community, no joke. Chill on the alcohol, ease up on the smoke. Realize there's hope, but you gotta catch it early though. Without a health screening, you won't even know. Get tested, pay attention to the signs. Talk to your doctor and check your behind. What's coming in and what's coming out. Healthy eating is always the best route. I suggest you talk to your family, your inner circle, and screaming and proactive, and it won't hurt you. We all want to live our lives the best we can be. Go check your colon. Peace, I'm Chuck D. Save lives, and keep the people meaning up to cancer. And get a screening. Save lives, take control of your health. Get knowledge for yourself, and it's the real wealth. Save lives, and keep the people meaning up to cancer. And get a screening. Save lives, I'm gonna tell you the deal. Colon cancer is real.
StandUpToCancer.org/colon cancer.
Thank you very much.